Good evening, everyone, and welcome to a very special evening with Dr. Wayne Phimister. He is a family physician. He is an assistant professor. He is an author, an international speaker, and a podcast host who is committed to finding solutions for chronic pain. He has developed a transformational fascial tissue release technique with trigger point injections for his patients and uses simple cognitive behavioral therapies and acceptance commitment therapy, ACT techniques to optimize neuroplasticity to heal pain. Now, Dr. Wayne has tailored his talk this evening because this talk was actually presented in the fall of last year to an international conference called Turning Point, and 500,000 people watched this presentation. And he's here to do it for us this evening. He also presented last month at the Medical Pain Conference that was based out of London in the UK. And so without further ado, let us introduce Dr. Wayne Phimister.
Well, thank you so much, Janet. Nice, kind words. And I really appreciate not only the welcome, but your friendship. And it's great to be invited back once again at Unity to share a few pearls that I've learned along the way. And tonight, the focus is the secrets of healing chronic pain. And to be specific, the talk is going to be about the secrets of fascial tissue and healing chronic pain. So without much ado, I'm going to open up the slides and share my screen. So you can just tell me, can you see those slides, Janet? I'm just going to do a few things here. 1 second. One second. I'm just going to unshare. I just need to change one thing here. Here we go. Right. So the secrets of fascial tissue in healing chronic pain. So we're going to split this talk into 3 sections. The first section is a small prelude into pain, how it affects people, how it affects society. And then we're going to dive into my personal and my vocational journey of this discovery of secrets of fascial tissue and healing pain. Then we're going to have a breakout. We're going to have a Q&A. We're going to come off the slides. We're going to have an opportunity to interact with the audience and in the chat room. And then after that, we're going to dive into the second section, which is a continuation of my journey, vocational journey. And it is into the mind-body connection, not just the physical, but the mind-body connection. So in fact, the next section is physical, and then the next section is mind-body. So 2 sections there. And we're going to have Q&As, breakouts. And then the last section, we're going to dive into how all this can be implemented into the medical system and how this can help heal our community. So we start at the physical level, we go to the mind-body level, then we go to the global level or the community level thereafter. So let's dive in. So my journey of discovery shows that healing chronic pain is possible by understanding and treating the fascia, and that's in the patient with chronic pain. So all my patients these days are patients with chronic pain. That's the only thing I focus on. So first we're going to start. Now, I don't know how your day's been, but my day's been very busy. And often with that, we are in a overdrive of the sympathetic nervous system with busyness. So let's take a 60-second meditation. And what I want you to do is just to focus on your breath. And we're just going to slow it right down. If you want, if you're in a safe environment, just close your eyes. And just focus on the inhale and the exhale, just through the nose. very slowly. Okay, so let's move on. So first, let's look at pain. What is pain? Well, the new definition of pain was updated a year ago by the International Association for the Study of Pain. And it noted that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, that's a little bit of a mouthful, but in addition to the main statement about pain, there's 6 additional key points, which really focuses on the personal experience that affects us biologically, socially, psychologically. It also includes those learned aspects of pain, because that's what happens as we live our life with pain. We learn how to live in pain or how to live in pain with dysfunction. And all these things are learned in the brain. In addition, it notes adverse effects on function. Pain affects our function, our mobility, our work, our hobbies, and also overall well-being. So these are the caveats that they added, because 40 years later, after the initial definition, they realized there's a wide-ranging effects of pain. And it's wonderful to see how that's not only included in the definition, but also what we're going to be talking about tonight. So the prevalence of chronic pain in the adult population, and it's similar in teenagers too, is about 20 to 33%. And that's an international statistic across many countries. It's rampant in our society. What's the economic cost? Well, in the US, it's about $600 billion per year for work-related losses, usually back pain, neck pain. It's a huge, huge toll on our society. So chronic pain is like the elephant in the room, the proverbial elephant in the room. It's there, but we don't really see it. And we certainly don't know how to cure it under the traditional medical model. But the good news is that neuroscience has now proven that curing pain is possible when you have a mind-body focus. So to begin the journey was my personal journey. And at the age of 16, quite unexpected to me, I started to have chest pain when I ran. I was a national level swimmer at the time, and it didn't make any sense that I could do many laps in the pool, but I couldn't run because of chest pain. So several years later at university, I underwent the typical family doctor investigations for this, with blood tests, x-rays, chest x-rays, etc., and nothing came up. And I was just kind of left thinking, well, maybe I just can't run. And I loved it. And that was a big disappointment to me. But the years rolled on and I got curious. And after med school, I looked into different therapies before, in fact. And the one that actually cured it was something called rolfing. You may be aware that rolfing is a deep tissue massage. The therapist gets deep into those connective tissues and these muscles all over the body. It was a 10-week course. She was releasing something called fascia. And that was my introduction to fascia. Now, 20 years later, I haven't had chest pain since. And within that 20 years, I've done 10 years of running, which I just hung up my shoes earlier this year. So let's move on to the vocational aspect of my journey, because just after my medical training in Scotland, I trained in acupuncture. And then several years later, I moved to Vancouver, the beautiful city on the West Coast. And I trained with the one and only Dr. Chan Gunn. He's an award-winning family doctor and pain scientist who trained in Cambridge in the UK. And he had set up the clinic called iStop, the Institute of Study of Treatment of Pain in Vancouver. And for all you Vancouverites, it's on Canby and 41st. So in Dr. Gunn's book, he explains what myofascial pain is. You know, it's myomuscle, but also if you look at that word carefully, fascial, myofascial pain. So there's two components there. And he teaches how to treat with dry needles. That's like an acupuncture needle into these muscles to release the knots. So that's what I started with on this aspect of the journey. Now, Dr. Gunn, in his research, came across the archives of medicine and the lost research from Professor Cannon from Harvard. He was a phenomenal physiologist last century, one of the top ones, in my opinion, because he discovered the law of homeostasis. That's the balance and equilibrium in every cell and every system throughout our body for health. And he also discovered the law of fight-flight response. And this was done shortly after the First World War, when he was dealing with shock victims in Europe with blood loss. His third law of physiology is called the Law of Denervation Supersensitivity. Now, this was written up in the 40s, but it was not published before his death in 45. And thankfully for us all, his wife did manage to publish it in this book in 1949. So I'm just going to read that quote at the top. I'll paraphrase it because there's a lot of jargon that's about 80 years old. So basically, when you get a series of nerves in the body, what happens is they get destroyed or damaged, affected. And this causes irritability. Irritability to chemical agents, because that's what he was researching at the time in the 40s. And there's not just the nerve, but the structures around the nerves gets affected or damaged. And this was his language. So where you get the maximum nerves, you get the maximum pain and maximum damage. So just to paraphrase that, you get irritability and hypersensitivity in damaged tissues from denervation. Now, the amazing thing was it was another 50 years before the landmark study in a Danish paper, 1996, on tension headaches, which discussed the term central sensitivity. And this is a term that all doctors are aware of now, and it's used extensively in pain clinics. But there was a 50-year gap, and that's several decades and several generations of physicians had no clue about what Dr. Cannon discovered and Chan Gun had been aware of since the 80s, 70s, and 80s and practicing in his clinic in Vancouver. So here we go. The law of physiology is bridged into modern medicine. Now, around the 1950s, there was a change because at that point, there was lots of research into psychosomatic or mind-body medicine. But the shift changed when penicillin was developed, and then lab medicine and imaging, CT scans, MRI scans in 1980, and also the big pharma expanded extensively after that time. And now we are here about 70 years later from 1950, and our focus on chronic pain is medications, injections, surgery, and therapy. That's the mainstay. And the interesting thing is mind-body connections or mind-body medicine is understood by almost every single patient I talk to. But yet we're still yet to see it integrated into the traditional system. Okay, so step two of the journey. This was after 12 years of practicing what I learned from Chan Gun. That was taking an acupuncture needle into the muscle, releasing the knot, and getting results to a point. And these days, extensively in BC and Alberta and in America, physiotherapists use this technique with great effect. But it was with this second step that I moved from dry needling to acupuncture, from acupuncture to medical needles. And these days, it's a traditional treatment used by many rehabilitation doctors, even in the emergency rooms, they're starting to use it. Family doctor practices, because it's very simple to do it. And we're now seeing this trigger point injection. So there's something called the regular TPI, a regular trigger point. So what that is, in this diagram here, you can see the needle inserted through the skin into this knot, this red circle with this fibrous nodule that can easily palpated in all of us. And I encourage you, if you're sitting in a safe environment, just feel your trapezius behind your shoulder. And if you just press down with firm pressure, maybe use your middle finger, you'll feel quite a tender point about the middle, right about here. So we have all got these tender points, but they don't necessarily go on and cause chronic pain. And one of the things you find when you inject, just like this diagram, is you get these classic patterns of referral, like the pain goes up from the trapezius up to the forehead, or it can go down to the shoulder, or it may just be local around the area. So these are the kind of things that doctors are aware of when you examine patients for trigger point injections. So typically there's about 1 mil to up to 5 mils can be injected in each spot, depending on how many trigger points the doctor's treating. And it's of good effect. Usually there's several treatments needed. And this is a classic trigger point injection. So as I was treating patients with this hypodermic needle, that's one with a hole down the middle where you can inject solution. And lidocaine is the solution of choice for most people. Something became apparent to me. There was more to this than just that one trapezius, for example, point. What about the whole area? What about the upper back? What about the other side of the upper back? What about the lower back? Because I'd learned through my journey with fascial treatment that fascia was everywhere. And I thought, well, we need to treat everywhere that there might be pain, not just what the patient's identifying. So here's a little recap on some fascia. As you can see in this diagram, the white areas, the base of the skull and the middle of the skull, down the middle of the neck, the back, all the way down to the lumbosacral fascia. That's the white section at the lower back and the lumbar spine area. And also very prominent around the SI or sacroiliac joints. Those are the dimples, if you look at your lower back in the mirror tonight. So this is where you see fascia. And also fascia is around the muscles, and it's through the muscles. And not only through the muscles, but it connects all muscles to muscles. So if you take a cross section through the muscle, you'll see lots of fibers like ropes, and there's multiple layers of ropes from big to small, and all of them have got this fascia running through it. Tendons, this is the Achilles, but all tendons in the body is made up of fascia. Ligaments, around all the joints in the body have ligaments to stabilize it. And also in specialized areas like the carpal tunnel in your wrist, the iliotibial bands down the outside of your thigh. And even around the joint capsules. Every joint capsule has got fascial lining. And even around the organs and through the organs, as shown here on the diagram with the lung, intestines, and the bladder. So my treatments look at the whole body. And when you have an active trigger point like the trapezius, you can treat that. But there's also something called latent trigger points, which is not known to the patient, but to the doctor who examines in more areas. So say you're treating on the other side, you could palpate and feel a trigger point and, oh yeah, that's sore, doctor, is the classic thing they would say. So you're feeling for these things in other areas other than the focal point. And not only trigger points, but something called tender points. So these are not knotted, these are just tender areas. Now, one important discovery I came across as I was going around the body, treating people with this, getting results, more and over above the dry needling technique, was the size of the needle. So here are my 4 needles that I would typically use from smaller to larger. So the smaller one on the right, the pink needle, that's the size called 30 gauge. And then slightly bigger is the white one here. That's 27 gauge, blue one, 25, and the larger one, 21. So I was using different sizes depending on situations and finding results. So what I did is I looked at all my audits of several years and all my patients in each year. And it started back in 2014 and 15. when I used those white needles. It was 27 gauge. And in the first year, there was 52 cases. And roughly, it was about 50% people neck and upper back, and also about 50% in the lower back. So equal spread between the areas. So this is a bar graph. And as you can see on the left-hand side, there's numbers, and that's a 0 to 10 scale, although you only see 9 to 3. So 0 to 10 scale for pain. And the red bar graph is related to before treatments, the pain score, and then after treatment. And that was not only immediately after, because I do approximately 4 to 6 sessions. So immediately after the 6th session, I would ask the patient, right, how's your pain score? And then that was maintained for 3.7 months. So I phoned them up about 3.5 months later and asked them, how are you getting on? So these were the results. So the pain was a drop in 8.4 to 5.3, which is quite remarkable. A point of 3 out of 10 is more than most medications. And that result was maintained, as I said, for about 3.7 months. And the function was just an arbitrary 0 to 10. 0 is no function, like incapacitated, lying in bed. And 10 is like doing whatever you want to do and can do. And just to compare the pain score, 0 to 10. So 0 is no pain, and 10 out of 10 is the worst pain imaginable. So here we are, the blue columns showing a reduction in pain and an increase in function. And a couple of cases I'll just enter into here is one of the early cases I ever did. I was just using saline solution, just salt solution. And it was a patient with 3 severe headaches, cluster headaches, migraine headaches, and tension type headaches. And I was treating many areas of his body, and nothing really worked. And I thought, well, it just makes sense to use lidocaine because it numbs the areas. So I went on to use 1%. And got remarkable results with 2 of the 3 types of headaches. And then about a year later, I was doing another case, a medical student, and he came in for his 4th treatment, and it wasn't really working. And I thought, 27 gauge needle, the white one. And he says, hey, doctor, why not use the blue needle, the bigger one? Because that's what his doctor had previously used. And I thought, okay. So within that one treatment, he had spontaneous resolution of his pain. Maybe I just got lucky, who knows? But from that day, I just thought, right, I think I'll use a larger size needle. And that got me thinking about the bigger the size was important. So what were the results? Well, overall response, and this was just me saying, look, how was the response? Was it nothing or worse? Was it fair? Was it good or excellent? And that was the scale. And, no, there was 8 people who said no response, 15 people, fair response. So that was about 47%. But the good side is there was 12 people or 23% with good response, and overall excellent was 30% of people at 53% total. So that's looking at function, it's looking at pain, and it looks at overall quality of life, just grouping all those things together. So next year I moved on to that bigger needle, the blue one, the 25 gauge. There was 85 cases, 57% more females, and approximately the same number of areas for 40% neck and upper back and lower back. And there was a few other areas like shoulder, upper and lower limbs, chest, wall, abdominal wall, and scalp. And the average age here was 55 years. So in this bar graph, again, the numbers on the left, 0 to 8 this time. And before treatment is the red column. And then immediately after the 4 to 6 sessions was the blue column. You can see a similar change. And then the yellow column was actually 7 months after when I called them up. Excuse me. So the pain reduction again was 8 to 4, as you would expect, according to the previous year. The function went up from 4 to 7, very similar, as shown by the blue column. And this remarkable result was maintained, much to my surprise. So these people were exercising, they were back doing the hobbies, they were working again, and I hadn't seen them for those 7 months. So the results were maintained. So overall, I got 76% excellent to good results, looking at pain function, or pain level, function, and quality. So that, the net effect was 23% extra benefit with a slightly larger needle. So me being me, I thought, well, maybe I can get better results with that 23%, 24% extra, and with a bigger needle. So one fine lady came in, she was a young woman in her 20s. She was working in retail on her feet all day. My treatments at that point weren't working at the blue needle. So I asked her, look, I think this will work. Shall we use a different size needle? I told her what was going on. So in the fourth treatment, we did use a bigger one. And lo and behold, one treatment, she was better. I saw her a few more times, and that convinced me that, yeah, there's something about the size of needle. So that next year, I looked at all 34 cases. There was 50% male and female. Again, about 40% upper back, neck, shoulder, lower back, shoulder, neck. Sorry, the second group was neck to gluteal muscle. So these were people with more pain, and I grouped them slightly different that year. There was the low back and the iliotibial band and the outside of the thigh that was 18%, and the limbs was 6%. So the bar graph again, similar again, 4 to 9 is noted as the pain score on the left, similar colors before in red, a reduction in pain, quite remarkably from 8 to 5.5 it was after treatment. And after 10 months, that was maintained, as you can see in the yellow column in the pain and part of the diagram. So maintained for the majority of the time, and the function improved from 4.5 up to about 6.5, and then it dropped down to just under 6 for 10 months. So this one, 60% of people responded good to excellent, and 10 months later, still a 48%, almost 50% of the original group were still operating at good to excellent with pain, function, and quality. So the theory here is the wider the bore needle, the bigger the hole injected, the more release of the fascia, of the muscle tissue. Along with it, tightness is released, and that allows the body to rehabilitate with less pain, more function, and more an improved quality of life. So third step in the interest of the journey was in 2018, when there was the discovery in the literature of something called the interstitium. I wonder if anybody's heard of the interstitium. Well, what is it? Well, this is the paper in the renowned journal called Nature. The structure and distribution of an unrecognized interstitium in the human tissues. Now, what's remarkable about this is Hippocrates, the father of medicine, 2,500 years ago, noted something called the interstices. He's talking about the same thing 2,500 years ago. And he was describing diseases and different fluid states in the body regarding disease. But yet it took all this time and about 200 years of pathological specimens heading off from the surgical table to the pathological lab for identification with a microscope. Despite 200 years of this type of practice, we were still unaware of an organ, and this is what the paper talks about, an organ in the body. It's absolutely remarkable. But this was a specialized endoscopic microscope. So the scope was into the mouth, down into the intestine, up into the bile duct, and they were looking, and they could see this layer around the bile duct, and they could also see it around different organs. So, and the reason why they couldn't see it is because when you take a specimen out of the body, the fluid disappears and the collagen or the fascia collapses, and all you see is this white tissue like in those earlier diagrams. So here's a picture of interstitium. So the top is the epidermis, that's your skin. And then you have this layer between the pink and the white globules, which are called fluid-filled spaces with pre-lymphatic fluid. So you've got the dermis that borders these two areas. And what happens in a chronic pain state and also in chronic inflammation? You get more fluid. So the white areas in the diagram, you get more of. And you can classically see that in some people around the cervical seventh vertebrae, but also anybody over the age of 40. And if you've got a crease in your neck, that's likely at C5-6, that is something called trophodema, which Cannon described. And this is all about this fluid that goes with chronic pain. Other names for this can be cellulite. I'm sure you know about that, on the thighs, the buttocks, and sometimes the arms. But this fluid is everywhere, and it's just above the fat layer in the body. So in this interstitial layer, there's collagen bundles. This is the red section that you can see between the white globules. And in chronic pain, these bundles tighten. And what happens is they constrict the blood flow. And as a result, this causes a problem called hypoxia, which is reduction in blood flow and oxygenation to the tissue. And that was highlighted in a great paper in 1997 in the journal called Rheumatology International. So one thing that's very apparent when you listen to patients is there's two things going on with pain. The first is the pain that they're complaining of, but under the surface, just like the iceberg, there's something called tightness. It could be a stiffness of a joint. It could be just, I just don't feel loose these days, doctor. I haven't quite got back to my pre-injury mobility of a joint. And the great news is that this tightness can be released. And that's what the TPI is, the trigger point is all about throughout the body, is releasing this tightness. And it can reverse it in many cases. So another theory of what's going on here is there's actually crystal formation happening in the fluid. So some of you might be thinking, well, this is a bit of a jump to talk about crystals, but not really. If you break it down and think about this, fascia is tightened fascia. So it's like squishing the area. And usually with chronic pain, it's continuous or it's chronic, at least chronic. And there's a very famous orthopedic surgeon called Robert Becker in the 50s, 60s, and 70s. He did some foundational research around this thing called piezoelectric charges. And that's the electric charges across tissues. And he was able to show growth and healing around bone fractures. And I believe that this electric charge is charged up with the sustained tension and pressure around the fascia. And a lot of the idea from this comes from the one and only Dr. Emoto, a Japanese professor who wrote in his famous book in 2006, The Hidden Messages of Water. It's really worth a read if you want to get into this. Shows crystals are formed in the water all the time based in the environment of the water. So for example, there's a picture in the book of Vancouver and there's beautiful crystal. And there's a picture in the book of downtown Mexico City, and the crystal's deformed. When you send love and blessings to water, he could take pictures of beautiful crystals reflecting the love and the appreciation of the water. Where if you send it bad vibes or heavy rock music, then the crystal change and deformed. So it's not too much of a stretch, I think, to think with this sustained pressure in the body that we're stimulating these areas, causing crystals. And if you just think what it'd be like to walk on a crystal, it's not very nice. So if these little crystals are in this tissue and you're moving your tissues and you're moving your body and it's sore, well, this could easily be going on. And the other example from nature is, think of coal in the earth with the heat and the pressure, a bit like fascia and pain. And over time, that changes to a diamond. So that took me on to the fourth section of my vocational journey. And this was, 2,000 patients plus later. And that's equivalent to almost 200,000 pokes or injections. So I've done a few pokes over the years. What happens is the needle blunts. And the reason I know that is because there's a noise, like a grinding sound as the needle penetrates through these tissues. And then the sound goes away when you take away the needle. And to be honest, I didn't know what this was in the early days. And I was talking to a patient who's a hunter. And he was saying, oh, yeah. No, when you hunt moose, you need multiple knives because your knife gets blunt. I went, there we go. So the fascia is a little bit like sinew. Imagine chewing beef for all you beef lovers versus chewing fish. Now, you know what I mean, because beef is chewy and it's got sinew and it takes a lot to break it up. Whereas fish melts in your mouth. So these are kind of the examples of what I think is going on in the body, in fascia, contributing to the chronic pain with this crystal formation and pain receptors being triggered. So 4 factors that I became aware of that led to this concept of thickening of fascia was age. The older you are, the more likely it is to be there. Traumas, past traumas, definitely cause more tightness in pain areas. So that's another area. Stress and pain is one of the biggest stressors of all. And the last one, a very obvious one, if you think about it, is surgical scars. You know, you heal the body through a scar, you tighten all the tissues up, and there's a nice scar there. But that is the tip of the iceberg with the fascia, because the fascia goes underneath and it goes all over the body, and that tightness can spread like wildfire. So the cause of pain, I believe, is reduced blood flow to these tiny nerves in the tight myofascial tissue. This reduces the oxygen to these nerves and also nutrients. It's never a good idea to have lack of oxygen and nutrients to nerves. And then you get the symptoms that we've talked about: tightness, stiffness, chronic pain, but also other symptoms like numbness, pins and needles, weakness, cramps, spasms, and the cycles can go on until it becomes permanent. And these are very common symptoms, and they're all a variation of the same thing, an abnormal functioning of the nervous system. In a very interesting book, the Janet Travell's book, it's the authoritative text on trigger points by David Simmons and Janet Travell, and talks about two types of myofascial pain. One is the specific form, and the whole 2 volumes are focusing on these treatments, and that's what we learn about in our schooling. But there's also something called this general muscle tightness, and I think this is what the fascial layer is in the body, and it's certainly what I've seen with over 2,000 patients. So let's discuss another case. Karen is a patient well known to me now for several years. She had chronic back pain when I met her for decades, 3 failed back surgeries. She was on opioids for decades, and she was off work. I was kind of the last stop, as I am for many patients. And we did some fascial treatments in the low back, and every week initially, and then it moved to every 2 weeks. And then over time, I just see her every month as a top-up treatment. And now she's 90% pain-free. She's off medication. She's lost a ton of weight. She looks amazing, and way younger than she did 4 or 5 years ago. And she's 100% active. It's amazing what this lady can do with her exercise, between hydrotherapy and hikes, and just at it every day. And another lady from this year, I treated her recently, left knee pain with that fascial capsule pain that we talked about. And also the foot was painful in the underside, so she had a fasciitis there. Failed regular treatments as normal is what I see in my clinic. 2 treatments of TPI, and the pain was gone in the knee. And that's just a slight under the surface release of the fascia around the knee joint. And her exercise is normal. She hikes many miles when she goes there out in the community now. And I've done about 12 injections and now stopped of the foot. And her numbness is resolving, and she is 100% active. So to summarize, what is this trigger point treatment? There's 3 that I'm aware of, and 3 that I practice. One is the regular, that's into the knots. And that's your classic neck pain, back pain, migraines, tennis elbow, shin splints, and other limb presentations of myofascial. And then you got the fascial presentation. The classic is carpal tunnel in your wrist, plantar fasciitis in your foot, osteoarthritis of knee, which is often and easily treated with this treatment, because it's not just inside the joint, it's around the joint for the pain. And then you get soft tissue pain around the ankle and the foot, where fascia is the predominant cause. And then a third treatment that I've added to my repertoire, and I've been doing this for a year now, and it further revealed further secrets of what is going on in this chronic pain state in the body. So hydro-TPI, what is it? Well, you inject a concoction of lidocaine, saline, and that's just salt solution, about 1 to 5 mils, with a tiny dose of methylprednisolone. That's just a small steroid that we use. We focusing on the certain peripheral nerves. These are nerves that are small nerves that are coming up to not too far away from the surface, but embedded in either the fascia or the muscles. And in the neck, classically, it's about 1 mil I would inject, in the lower back and the gluteal regions, the buttocks, about 5 mils. And the whole goal here is to numb the area for 2 hours, And then by the time patients leave the office, basically the pain is gone wherever we're injecting. You irrigate, so you wash it out. You hydrate it, so you give it a drink. And you detoxify the chronic inflammation that's in the tissues. So chronic inflammation is the cellular reality in chronic disease. And that's all chronic disease. It could be pain, it could be obesity, it could be diabetes, coronary artery disease, cardiovascular disease, cerebrovascular disease like strokes, autoimmune conditions. Common causes I see in my practice are foods like grains, sugar, the nightshade vegetables, the skins and seeds are causing inflammation like a tomato and a pepper. Stress is a cause of chronic inflammation, negative thoughts and negative emotions, and that's triggered by the overdrive of the sympathetic nervous system. And then you get this vagal dysfunction, which is the opposite side of the autonomic nervous system is not working properly. And, I've had hundreds and hundreds of cases now that are being corrected by looking at these different parameters for inflammation. One of the leading researchers in the planet is Dr. Serhan at Harvard, and he's developed biological pathways and shown biological pathways for this theory of chronic inflammation in pain. And I'm very happy to say that I met a great guy called Mike Perry on my podcast show over a year ago now, and he is a nurse anesthetist in Nebraska. And he has developed this technique of hydro-TPI for the last 20 years, treating 15,000 patients. And he irrigates the tissue, he hydrates the tissue, and he detoxifies the chronic inflammation. And it's interesting, he was describing to me in the early days that there's a glue in the tissues that is called hyaluronic acid. And it comes out through the body through a mixture of blood and like a clear fluid. And you can test it and send it off to the lab. That this chronic inflammation cells is causing an acid in an acid environment, which is not a good idea because it sticks the tissues down and therefore you can't move them. And the longer the duration of the chronic pain, the more intense the mental, emotional issues, then all these things are compounding. And then you get this horrible state that needs to be released with this approach. So this is what I do for the 15% of cases that I can't get better with the regular treatments. And the results are quite phenomenal. So here's a case from last year. Eric is a 34-year-old guy. Unfortunately, he was run over by a car. He was knocked off his motorcycle and the car reversed over his leg, smashed his leg, multiple fractures in the right side. He failed the traditional rehabilitation after the initial healing. I did my regular TPI, didn't work. So I moved on to the hydro TPI. And now he's 100% pain-free in 2 of the 3 areas in his leg. And the other third area is 65% pain-free. And now he's in active rehab. So here's a picture, a few pictures of the technique on one of his treatments. So this is the injection. It's a saline lidocaine mix and a small amount of depomedrone, the corticosteroid, about 1 milligram, which is a tiny dose. If you note on the diagram where the red arrow points, you can see that's about 7 mils of fluid in the injection. So as I inject the area, it starts like this. And then there's a tenting of the skin. And the next slide will show it better. But as you can see around the red circle, you maybe appreciate a slight difference in elevation of the skin level. And also note the syringe, how much fluid's left. There's about 2 mils of fluid in that. So it's 5 mils injection. This is a case I just saw 2 days ago. And this fella was gracious enough to allow me to picture his neck. And as you can see on the left is flat and on the right is elevated. And you can see that shine around the black dot. And that's 5 mils of, about 3 mils of fluid in this one. So that's tenting of the skin. So after you do the tenting, you inject the needle into the tissues and you do it in a fanning direction, like maybe 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, back to 12 o'clock. And what happens is it starts to allow this fluid to move down into the channel or the canal into the layers of fluid. You put pressure on, so you're pushing that fluid down and you're hydrating, irrigating, and detoxifying the layers. And what happens is, and I've just pulled the diagram back from a few slides ago. So you can imagine this layer is now filled with fluid. You can imagine an injection, a needle right into the middle of it in multiple directions. And all of a sudden, the canals are open up. And this drainage system, a new drainage system, literally drains into the lymphatics, which drains into the venous system, into the heart, and then the arterial system of the body, and then out through the kidneys. So we actually remove fluid that's collecting. And I've had multiple patients treat fluid, not just pain, but fluid collection in these encased areas under the skin in this layer. So this is the end of the treatment. The effect lasts for 2 hours because it's lidocaine. And then as the treatments go on, the effects last longer and longer. And now about 7 months later, Eric is pain-free in 2 of the 3 cases and doing very well. His pain level is 5 out of 10 in one of those areas. Questions? I'm just going to take off the slides and we're going to do Q&A. Okay. Are trigger point injections for musculoskeletal injuries only? No. All chronic pain that, or I would say almost every element of almost all cases of chronic pain, this can be used for, because you cannot really separate the fascia from diagnoses. When doctors give patients diagnoses, and they differentiate all these areas of the bodies with these terms like shin splint or tennis elbow. And really what it is it's a continuation of the same thing. So what my practice is, chronic pain is chronic pain, and you can certainly treat most with this technique. I think one exception would be very sensitized patients, like complex regional pain syndrome. It's too sensitive for needles, so I often would not treat. Cancer patients I wouldn't be treating because that's not really appropriate. But most of the chronic pain is coming from soft tissue, and you can certainly treat. You mentioned the fluid in the needle. What is it? I have had dry needling before, but not. Okay, so the big difference between the two is dry needling is no fluid. There's a solid needle, stainless steel, that goes in and out of the tissue, and there's no fluid, no injection. And I did that for 12 years, so I'm well aware of dry needles, and it's good to a point. But after a certain point, it doesn't work, and that's my experience. So with the fluid, as I mentioned, lidocaine is the most common one used, but you can use others, Marcaine, other local anesthetics. The doctors sometimes use corticosteroids or steroids directly. I don't think you need to use that, although some doctors do. And then there's the more advanced technique, like I've described, with the combination of saline, lidocaine, and the depomedrol. Yeah, okay. How does the thickness of the needle you use compare to acupuncture needles? And the 30 gauge is tiny, and I do use it for small areas in the face, and that's about the same size as an acupuncture. So, but I think you can get smaller with acupuncture needles, but that's the kind of classic size you can use. So about 30 gauge. Other doctors in Vancouver that use your method, I can see. Yeah, the great clinic, my good friend Rav Danoa runs the Muscle MD on Broadway in Vancouver. And also he runs a clinic in Delta. So if you're in these areas, you can certainly phone up the clinic and get these trigger point injections. He does the regular TPI, that's just focusing on one area. And what I'm describing tonight is something I've developed myself. And as far as I'm aware, not many people do that technique. And I'm pretty sure nobody does the hydro TPI, because it's quite a rare technique. I know there are physicians in Toronto who do it under ultrasound guidance, because I've talked to them on my podcast show. So might these treatments be covered under medical plans? Yes, absolutely. Trigger point injections is covered by the normal plan. So one thing I'll just say, there are quite a number of doctors. Just Google your area, trigger points, and see if there's any physicians in your area that may accept patients for it. That's a good idea. I know I trained a physician, Cam Gross up in Prince George, and he certainly does trigger points. And there's numerous nurse practitioners that do it. And I've trained several. I've trained about maybe 70, 80 physicians or nurse practitioners over the years for this. How does this compare to Prolo? Prolo is slightly different. Prolo is focused on the ligaments around joints. And I do have some patients that go for Prolo, and can be very effective depending on the situation. It's very painful. I've had it done myself. A good friend and previous colleague did it on me because I had to go and experience it. He did trigger points and he did a Prolo. So it's quite intense. But one recommendation for that is make sure there is ultrasound guided procedure. So you want somebody who's got an ultrasound handheld device at the same time, because it's tricky to get the exact area, and you really need that specific ligament because they can be very small in the joints. But Prolo can be very effective treatment. What is the fluid you're using? I read saline, but are other fluids chemicals? Well, as I previously said, there's local anesthetics are used for regular TPI. And, you know, if you're in the ER and they're doing it, then they'll likely use lidocaine. Same what the dentist uses to freeze your gum for dental procedures. And you can use other local anesthetics. Marcaine is one that I've used in the past. It's a longer acting one. And then there's the corticosteroids, the depomedrone and other steroids are used. But again, I don't think you need to do that. And just to give you a comparison, because I did mention steroids, I haven't really given you a comparison, but if I treat one case with my hydro-TPI every week for 12 weeks, that would be a lot of treatments, but that would be the same amount as if you rolled up to your family doctor tomorrow and got a steroid injection in your knee. So it's a tiny, tiny amount of steroid that's going into the body. And my good friend and mentor, Mike Perry, hasn't seen any side effects from steroids into the body from that small dose. So will this help reset sensitized pain? Absolutely. So Lorimer Moseley has been cited here, and he's a leading pain scientist in Australia, and has written a great book called Explain Pain with David Butler. And the book's all about hypersensitized tissues and how the nervous system gets super sensitized, as Cannon says, or in a severe case, central sensitivity, which is now in the literature and discussed. But yeah, you literally are starting a process where you send a signal to the brain, and then the brain for 2 hours switches off the loop of sensitization. And then maybe it only happens for 2 hours. Some people get relief for a few days. And as the weeks go on every week, then I find that the duration of benefit is longer and longer. So it's not a chemical desensitization, it's a mechanical, because you're releasing the tightness in the fascia. And as a result, there's more and more signals going to the brain of switching off this sensitized autonomic nervous system. And when I come on to the next couple of sections, we really dive into how you can maintain the effects of trigger points. And this is why I love doing it. This is why I do it all the time, because it's like a starting point for that long-term recovery. It can be quick sometimes, but often it takes a while. And it just jump starts the body into this healing modality, which is a predominance of the parasympathetic and the healing state of the nervous system. Does this treatment help end stage osteoarthritis with MRI shows no cartilage? Brilliant question. And many people don't believe me when I say this, and I don't expect people to believe me, but I've seen it and I've heard many stories. It's just because you've bone on bone, it doesn't mean to say that the pain can go away. And my good friend who wrote in my book, his name's Tim Brown from San Diego. He's been on my show a few times, and he shares a case in my book that this woman came in and had bone on bone in the hip. And with 4 treatments, of positional. And he's a physical therapist using the Goscu method, which is all about posture, alignment, and maintaining that optimally through specific exercises, which is not a traditional thing to do. And he found 90% pain-free with 4 treatments in this one case he shares in my book. And it just amazes me when you dive into this world that the labels or the diagnoses that doctors give patients is not the reason for the pain. And the evidence clearly shows this, because you can take 100 x-rays or MRI scans, say of a lumbar disc, and this ties into the question. And the radiologists who look at the 100 MRIs of, say, degenerative disc, bulging disc, and prolapse disc, 100 of them, you cannot tell who's got pain and who doesn't have pain. And say 50% of people got pain and 50% don't have pain, but they've all got the same type of severe osteoarthritis in the back. You cannot tell the difference. And I think we're doing our patients a misservice, and we're actually prolonging this cycle of chronic pain, because we need to educate about things like fascia, things about neuroplasticity, which we're going to talk about, and also the mind-body connection, because these things are clearly shown in the evidence for over 10 years now, scientific proof that we can heal pain, we can cure pain if we start looking at it. But that's not yet a reality, unfortunately. Yeah, is it possible to have pain with no cartilage? I think it is possible in your knee. Yeah, we're a physically focused medical system, and we treat people like something's broken in the car, right? And we try to fix it, but it doesn't work, because you're just using a stethoscope, or you're just using an X-ray or an MRI scan. You're not opening up the hood of the car bonnet to look at the engine. You're not actually looking at the problem. And that's where the nerves are. This is where the hypersensitivity is. This is where the inflammation is. All things that can be changed, I believe, and I see all the time. So it's time that we actually looked at the real problem that the scientific proof it now shows. Are these treatments required for life? No, not everybody. Some people, maybe yes, I would say, but my whole focus is to try and get people off treatments. And some people do need maintenance once a month. Very few people come once a week. It's the only thing that works. And then maybe other comorbid condition that complicates it. But no, the focus is changing the brain to change the pain and therefore heal it. Recurring sciatica, absolutely. Sciatica is just a Latin term for pain going down the leg. It's not specifically nerve impingement of the sciatic nerve, which everybody thinks it is. Not always. It can be gluteal muscle myofascial pain. Different than intramuscular stimulation? Yes, absolutely. So IMS is dry needles. This is a hypodermic needle, and it's chalk and cheese. In my experience, chalk and cheese difference. Because the dry needle doesn't release fascia, not to any extent. That's not the purpose of the needle. The needle is supposed to slide in and out without traumatic influence. There is a trauma, but it's nothing like the cutting action of a hypodermic needle. Do we need a referral from a family doctor to have an appointment with you? Yes and no. You don't really need it. I have a clinic in Fort Langley, which I'm actually wrapping up at the end of June, and I'm going to be full-time in Abbotsford. So ideally, get a doctor's referral to the Abbotsford Clinic at New Leaf Wellness. My website, waynefimister.com, has all the details. But if you can't get that, just self-refer and I'll help out. Just curious, if you modify your treatments for central sensitization, absolutely. Yeah, trying to take into consideration every patient with every visit, because it can change from visit to visit. And I don't always do the injections either. Sometimes it's not the right thing to do. We chat and we focus on the other modalities, which I think are actually more important than the trigger points. So thank you. Lots of questions. Okay, let's get back to the...
Okay, Wayne, we have one other question here that just came through, and that is what you're doing effective for referred pain? In other words, pain that's coming from one part of the body as on being felt in another part of the body. In this case, one foot hurts a lot, but there's nothing wrong with that foot.
Absolutely. You know, the analogy I like to give is a bed sheet. You know, what happens when you pull a bed sheet? Janet, what happens when you pull a bed sheet? What happens? The whole thing moves. It moves, right? The whole thing moves. So what happens with pain is there's tightness happening all the time in lots of areas. And so you can have pain in one area, but tight in the other. And if you treat one area, the pain can go away, but the pain comes up in the other area, and it's like peeling an onion. There's layers and layers and layers to this. So that's one answer. The other answer is the brain decides where you have pain. And the brain, you can wake up the next day and go, okay, we're going to give you the left foot pain. Yesterday it was right foot. Today we're going to give you left foot. And you think you're going crazy because there's nothing wrong with you. The tests are negative. It's just fascia. It's just the brain. It's the program. See, it's not a physical problem. It's a program problem. The program up here needs to be reprogrammed in order to heal it.
So that would help with referred pain then.
Yeah, and referred pain is, you know, like most referral pains is not in the characteristic, what we call dermatomal or myotomal or sclerotomal pattern, which just means, you know, the direction of the nerve or the pattern that comes around the muscles or the bones, down a leg, for example, refer pain down the limb. Most of the time, it's not following the nerve route. Like we all learn this in med school about, oh, this nerve's impinged in the spine and then it gives you pain in the foot and it must be impingement on the spine. No, most of the time it's not. And the reason I can say that is I poke people with needles all the time and they get better, right? I'm not changing anything near the spine. So, yeah, there's more going on under the surface than meets the eye.
So we've got more to have Dr. Phimister, Dr. Wayne present to us. And now we're going to be going into the section on mind-body connection.
Yes. Okay, so sixth section. And one of the amazing things, right, well, here we go again. Let me just do this properly. Just give me a moment, please.
We're now seeing you, Wayne. We were seeing the
that's fine. Here we go. Before. Yeah, we're just getting it back here. Okay, so here we go. So number 6.
Dr. Wayne, we have the same situation where we have your notes on there. You were good before.
Yeah, it disappeared. Yeah, that's crazy. Anyway, let's just go with it. I know what to say anyway. Okay, let's do it. So
we still have the screen up, love.
What's that?
We still have the screen up.
Do you have the slides?
Yeah, no slide, just
really?
Just your notes.
Okay.
Yeah, you select the slide. You're doing it. You know what to do.
Right, what have we got now?
We've got your notes, and then on the very far left, we've got just a very tiny slide that needs to become full screen. Oh, now we're back on spotlighting you.
Sorry about this. So I'm just going to do this.
I'm so glad you're a Zoom. You know what to do in Zoom.
Well, struggling a little bit today. I don't know what's going on. So, okay, what do you see?
There we go. That's good.
Okay, so let's move on. So number 6 is, what is this mind-body connection and what has it got to do with fascia? Well, over 2,000 patients later, there's several findings that I realized as I was going through this process of thinking about mind-body connection and just identifying the different aspects of our bodies and our minds. And the classic things, I'll just share some of the stories that some of the symptoms that patients find, like they have less pain, they've got less tightness, less stiffness, their mobility is better, their function's better, their hobbies have returned. So these are just normal things. And we're looking at the fascial layer, the muscle layer, the physicalness of our body. And this is happening with patients. The mental level, well, depression gets better because their pain's getting better. Their anxiety is improving. Overwhelm is getting better. And clearer-minded patient this week, and I was asking her, and she says, yeah, I've just got more clarity of thought. In fact, one patient this morning said the same thing. Emotional. So the emotional level that comes, which ties in with the mental, but it's just a freedom in their ability to function in society, like to be able to operate with family members. Their emotions are more stable, and therefore they can be more effective. Spiritually, people's passions return, their missions in life, their hopes for their life back, life transformation. These are the things that people say when I treat them. And remember, these are patients who are not, regular family practice. These are patients who have gone through the system, have tried most treatments, and then they get the release of the muscles and the fascia. And then they're finding that this multi-layer effect on the body. And then out with themselves, the social effects. Their relationships are better. Their intimacy is better. Able to work, and the list just goes on. But people's lives are transformed. So let's move on to the energy and the electromagnetic theory. So I'm just going to go forward. Yeah. So with my training, I did some training over the years in energy medicine as well, because I'm open to all modalities of healing. And with the training of Sue Morter, who wrote the famous book called The Energy Codes by Sue Morter. She's in Illinois. She's a chiropractor. And she was discussing in our advanced class on chakras and what the functions are about the 11th chakra. Now, many of you know about the 7 chakras. And on this diagram, you can see 1, 2, 3, 4, 5, 6, and then the 7th one is above the head. So these are 1 to 7, and they're all related to different things like colors. They're related to organs, where they're located, and different functions in the body. But when you go out to the aura of ourself, and as you can see in this beautiful diagram of energy around the body, there's the 8th, 9th, 10th, 11th, 12th chakras. And the 11th one is the highest vibration, where you cannot, or the vibration where beyond it, you cannot feel. So it's the one that's the most fine vibrations that you can tap into and be aware of. But the amazing thing is, what I learned in this course is it's related to fascia. It's related to connective tissue. It's related to skin, and it's related to muscles. And it just made a lot of sense to me when I was seeing all these effects on patients and all these layers, and then understanding that we are not just minds, and we're not just physical bodies, but we are spirit, mind, body, spirit. We are energy. And there is an understanding and science around this 11th chakra. And the reason why people get better in all these layers is because every layer is affected when you treat fascia. And one good way of thinking about it is, many of you know about meridians and acupuncture. Imagine that those are the highways going to your destination. If you're driving from, say, many people are here from Vancouver, so Vancouver to Hope, you stick on the highway number 1 and you get to Hope. Well, what about the fields? What about all the fields between all the roads? And you think of the roads like the meridians. Well, the fields, as you travel, is like the fascia. So if you poke these and you open up the tissues, you get this interconnected flood of energy flowing around the body and an opening up energetically, but also physically, as I discussed earlier. So it's beautiful to understand the electromagnetic nature you know, I'm sure we all appreciate that we live in an Earth that's got a North and a South Pole, and it's got effects with the tides on the lunar cycles every 28 days. And we live in an energetic magnetic world, and that's also true for our bodies. And that's what's going on, I think. So let's move on to neuroplasticity, the science of how your brain can change. Just like plasticine, you mold it, you change it, you have a different creation. So our brain are neuroplastic. And the science pioneer John Sarno, was the guy in the 50s, 60s in New York who really took on board this idea of mind-body medicine. And he helped 10,000 patients go pain-free with this concept that you can tell your brain to have a different thought or a different belief pattern. And this in time changes the neurons and the circuitry of the body and of the brain. And then his students that came after him, David Schechner in LA, Howard Schubiner in Michigan, David Hanscom, a good friend who previously was in Seattle, now down in LA, have all done, you know, written great books, and I've got great courses and tools out there on the internet to help with this mind-body connection. Joe Dispenza, the one and only Joe Dispenza, and I'm sure all of you listening from Unity know his name. He's the pioneer, a neuroscientist who's done over 10,000 functional MRI scans on people, watching their transformational change to healing, and looking at lots of parameters, not just functional MRIs, but also blood testings, DNA testing for telomeres. And it's his book is Becoming Supernatural is his latest one, I believe, about 3-4 years old now. And he clearly shows that our brains are neuroplastic, and through the neuroscience and understanding it, that we can heal. And Caroline Leaf, a great neuroscientist, been at this for 38 years. Her latest book called Clearing Up the Mental Mess has a wonderful 5-step process of neurocycling to really deal with our mental thoughts on every 10-second basis. And she has these little programs that she gets people to do that really works well. And I've been using that myself as well as with patients. So these are some of the pioneers. Epigenetics, what is this? Well, epigenetics is what is around or above epigenetics, your genes. So what is around and above your genes? Well, it's your environment. So what the science of this shows is that inside our brains, we produce neuropeptides, and thoughts and emotions that are happening all the time, happening from the moment we're born and even before, are creating these peptides, which are proteins in the brain that go into the body through the blood, around the body, up into the cells, into the DNA, and therefore programming the DNA. And if you multiply that by 30 trillion cells, that's you and me, we have an ongoing system that's regenerated and changing through neuroplasticity and affected by the environment. And this is why the mind-body connection is so important, because it matters what you think, it matters what you feel, what you visualize, what you do, how you breathe, how you work, how you deal with your family, friends, lovers. It's very important, because when you take all these things in consideration, you start to change your body, and you start to on the journey of healing. Bruce Lipton, in the previous slide, has written a great book, and anybody listening out there who hasn't heard of this guy, I strongly recommend you read his book, The Biology of Belief. And my opinion, all medical students and all therapists should be reading this book to understand this basic principle that has now been around for, in fact, it started in the 40s in Edinburgh, but in the last 20 years, it's really taken off and exploded with the number of research articles per year. So long and short of it is, we are programmed for pain. We are programmed from traumas. A great pioneering research article based on trauma from 1989 called ACE, Adverse Childhood Effects, clearly showed that traumatic effects in childhood are cumulative and they cause disease and they cause early death. And people like Geber Mate, Bessel van der Kolk in Boston, and Peter Levine, PhD, have all written extensively on this concept of trauma affecting the nervous system. Because really what happens is over time, over our life, and it can happen from trauma like abuse, neglect, but it can be something like separation anxiety, which happens in all of us at different stages. But there was a great study by a gentleman, a psychiatrist in Pennsylvania in 1989, looking at 9,000 psychiatric patients. And he was able to determine that the average age of separation anxiety for these 9,000 was age 2 in 2 months. So at a very young age, we have less time with our parents as we grow older. Maybe there's a sibling. So not only traumatic things or neglect issues, which are horrible, but just normal life things like a sibling coming into your family can cause separation anxiety. And these things are programming the brain and the autonomic nervous system. And as a result, leading us later for disease and also pain. So you may have an MVA, a motor vehicle accident, or a fall, and you have an injury and you never get better, but that's not the cause. That's the trigger for the cause. The cause is the whole life of programming. And the wonderful news is we can reprogram it. Okay. And let's just turn this over to the Q&A. So any questions around the mind body? 2 questions. Okay, there we go. Does TPI stimulate neuroplasticity? Yes. What is the mechanism? I believe the mechanism is to move the nervous system from the fight flight to the rest and repair, because you cannot heal if you're under duress, under lots of stress. You know, if a cougar's at the end of your street, you ain't going to be sitting around and having fun and, you know, drinking a margarita. No, you're going to be doing action. You're going to get inside. You're going to bolt your doors. You know, you're going to call the police, whatever. You're going to be in action. So pain is like that. You're constantly on supervigilance night and day. The program never stops. So it's very difficult to heal. But the trigger points, I just think gives it a break, and I'm releasing tension. People who do this release the tension in the body. And the opposite of tension is relaxation. And we need both. We need a mixture. But with the pain, it's tension is on all the time. So as you take down the tension, you start to allow relaxation. It's like an automatic flip. And the next section, I'm going to be doing a meditation with you, which will highlight this, and I'll speak a little bit more about it. Any questions?
We have one here from Ryan.
Hi, Ryan. Okay, I do meditation and counseling, and I've had my muscle tightening and holding loosen. Yes, exactly. However, the new range of motion is quite painful. Maybe it's 5. Yeah, exactly. You cannot take away fascia from MSK pain, guys. You can't do it. Because it's in, you know, when you've got a muscle, you've got fascia. Fascia is everywhere. It's the unseen organ. It was not even known 3 years ago, for crying out loud. It's everywhere. And it's definitely part, in my opinion, of your pain. So trigger points, fascial trigger points is a good idea, in my opinion. Okay, many here have been studying Becoming Supernatural by Joe Dispenza, which of his practices do you find the best for relieving pain? Oh, great question. Well, I think one of the 2 things, and I'm going to demonstrate this in my safety meditation coming up, but I think the 2 things that stand out are visualization and the embodiment of the positive feeling that generates a neurochemical changes in the body, hormones, peptides, transmitters changing. So you run away from that fight flight, and then you move into that relaxing, you know, bonding hormones of oxytocin and happy hormones of serotonin and reward hormones of dopamine, and endorphins, our natural morphines and other substances to reduce pain. And these chemicals are lasting, and the work with Joe shows up to 6 hours, 6 hours of these hormonal changes. And cortisol dropping is the opposite side of this. Homocysteine levels can drop with this. So we're literally changing our biochemistry while you visualize and while you go into the emotional states, which we'll be practicing. And I think the third thing to say with Joe's work is just that persistence. Like the people who go to his workshops, and I've been to one, they don't miss a meditation, he says. No. It's like once you experience some of this, it's like you're going to do it because it's essential. And it's not an option. It's something you must do. So just persistence of faith, of belief, of mindset, visualization is really important if you're going to get that transformational change that he clearly shows with his patients and his clients.
We have a question here about rheumatoid arthritis and neck injury and the treatments.
Yeah, good question. So rheumatoid arthritis is a tricky one because you're probably thinking, well, this is a immunological disease, which it is. It's a genetic disease, which it can be. And, surely, trigger point's not going to help that. Well, it's interesting. I think it can still help the myofascial component because it maybe not get rid of the immunological changes of rheumatoid, but it can certainly help take away the tension that's associated with it. So that's my focus. And then the other focus with rheumatoid and other autoimmune conditions, and a patient comes to mind as psoriatic arthritis, quite similar in a way. And he just gave me an email last week. It says, thank you so much for the treatments. And, because I focus on inflammation, your diet, you must remove inflammatory foods from your diet if you want to heal. And, cooler showers and breathing techniques can all help to reduce inflammation. So when you look at the body like this, you can actually switch off genetic programming for diseases. When I went through med school in 1995, I finished, the idea was that, yeah, your brain's kind of stuck and it's just the way it is. And the genes you get are the genes you've got from your parents and good luck. No. The tables have turned. 95% is the number given that we can change our DNA through our thoughts and beliefs and our actions and our diets. And it's not just our DNA, it's the microbiome DNA in the gut, because that outnumbers me and you 10 to 1 on a cellular level. 30 trillion people, 300 trillion microbiome bugs as such in the body, mostly in the gut, are triggered for genetic codes. And there's 320 times genetic coding for them than there is us. So those guys are running the show. So I think absolutely rheumatoid arthritis can be switched off and certainly halted in its progression. Maybe not reversed, unless you maybe see Joe Dispenza. But, for most people, it can certainly be halted and the pain can be controlled. And neck pain, it can come with any, if you get rheumatoid arthritis, it's just another factor that can be involved in that. But again, the same rules apply. Oh, here's a good question. I don't know the answer to this. Erythromyalgia. I love it. I don't know what that is. So somebody's asked me the question. I'm just going to do this myself. So somebody's asked me the question, what is ERYTHRO, erythro, which is red blood cell, and it's MELALGIA. I never heard of that term. Now, it could be a term. So I'm just going to do good old Google. Do you still see me?
They've put it in the chat what it is.
Yeah. Okay. Here we go. Just Wikipedia. So let's just go into this. So I love this. So to everyone, here we go. So the question is, what is this condition? Erythromyalgia. melalgia. It's a condition characterized by episodes of pain, redness, hence the erythro, and swelling in various parts of the body, particularly in the hands and the feet. These episodes are usually triggered by increased body temperature, which may be caused by exercise or training in a warm room. Yeah, absolutely. This, what is pain? Pain is inflammation. So that's what the redness is. What is swelling? Well, swelling, as per the diagram that we showed earlier, swelling comes with the pain. So this whole condition is an extension of what Professor Cannon discovered in the 40s, where you get swelling and pain, but of course you can get swelling, redness, and pain. So to me, all of these things make sense and certainly can be treated with everything we're talking about today. So I don't have experience of treating that thing, but it's, there's variations of chronic pain happening all the time. Like numbness is a variation of chronic pain. And I just see it as the same thing. Burning face, limbs, central sensitivity, absolutely. So the nerves to the face are the ones that the brain is triggered to, for whatever reason, causing the symptoms. But yeah, I would focus on inflammation. I would focus on diet. I would focus on the mind-body connection, the belief in the core belief that this can go away. It's essential that you think this, even though you may not feel it. Yeah. What about nerve damage in the back and muscle atrophy in the legs? That this works? Yeah. Well, the term nerve damage, that's a very loose term. Many patients use the word nerve damage. Most nerves are not damaged. They're sensitized. They can be reprogrammed. Because before trauma happened, accidents happened, the body was probably working normally, or no pain, and therefore it can go back there because it's got the program. Which program is it running? Is it the healing program or is it the pain program? So atrophy can come back. It takes a long time, but atrophy is not necessarily associated with pain. Can be, but not always. Okay, what's this? Next, can you give suggestions about anti-inflammatory diets, what to avoid? What I tell patients, Google yes list, no list, plant paradox. Yes list, no list, plant paradox. And the big ones, the big five, I would say is gluten and bread, avoid. Cow milk, cow dairy products, corn, soya, and eggs. Although I think eggs are well, what I would say instead of eggs would be nightshade vegetables and the skins and the seeds. So you could Google nightshade vegetables, but tomatoes, peppers, zucchini, eggplant, cucumber. So that's foods to avoid. And just take your time with it. It's a lot. When you look this up, you get overwhelmed, and it's best just to do one or two foods at a time, change it. You avoid the no foods and you eat the yes foods. Are you currently taking patients, and what is the cost of the trigger point? Yeah, I take patients for pain, and there's no cost directly because it's an indirect cost through MSP. I'm an epigenetic intergenerational survivor working on healing and reprogramming. I am intrigued. Well, thank you for your comments. Yeah. What kind of diet are you referring to? An anti-inflammatory diet is the best way to describe it. I use the term lectins, but there's actually three main physicians that I follow. One is Mark Hyman in Cleveland. He's written many books. Food. He's written several books called Just Food. He's great. He's got the Pegan diet, a mixture of paleo and vegan. You got Sarno. You've got Perlmutter, David Perlmutter in Miami, I believe. He's a gastroenterologist. No, he's a neurologist. He's written several books. Brain Grain is one. He's got several books. Great guy, great work. And also Gundry, Stephen Gundry, who's got the plant paradox, and that's where I get my list of foods. And they all say slightly different things, but the take home is kind of the same. We must clean up the act in the microbiome in the gut. If you do that, you start to heal. And it is a trial and error. I advise my patients to do the diet for 4 weeks if they can, 6 weeks, and then personalize it. Eat certain foods, see what you think. You may have a pizza and not like it because it just causes too much bloating. Next person may be okay. Maybe a gluten-free pizza is fine, whereas the next one, that's not fine. So it really is individualized and important. Okay, we're moving on. I want to go to the next section. So I'm just going to share my screens.
And Dr. Wayne, we have about 25 minutes left, so I know you've got a few things you want to get in there.
Yeah, okay. Let me just do this. So the next section, but how? How do you heal? How do you heal? How can people listening today heal? So just briefly, step one, the physical specialist must know about fascial tightness, in my opinion. Then they offer simple office techniques like the regular TPI, as we've discussed, fascial TPI is discussed, and then the hydro TPI to remove the chronic inflammation. So these are things that can be done in the office. So that's the step one. Step two, what about other people, therapists, your physio, massage therapist, your chiropractor? Well, they can release fascial tissue too. And many have been trained in fascial releases, and they do this as a part of their job. So you can look out people who do this, and this may be sufficient. I know naturopathic doctors do the Bowen technique, which is basically the same thing, and very effective. And then in more complex cases, after TPI, so I refer my patients back to the therapist to continue on their treatments for rehabilitation and other treatments. Then you go on and rehabilitate. So the third section is people. So people need to be aware that they can heal. And I believe the key is awareness. Awareness is the bridge between actions, all the things we do and the tools and the methods that you have, and the healing state that's deep within the DNA of the body. So how do you do this? This is a brief overview. Thoughts, write them down, see what they are, start changing them, get away from the negative, go to neutral. Be neutral in your thoughts. If you can be positive, be positive. Words, affirmations. I love the Emile Coué statement, every day in every way. I am getting better and better. I had a patient who said that every day, all day, and her chronic pain of 49 years vanished in 4 weeks. Vanished, hasn't come back. Affirmations are important. And the other way of words is not to talk about pain unless it's your doctor you're talking to or a therapist. Don't talk. Don't talk about it. Whereas energy flows where intention goes, as Joe Dispenza talks about. Core beliefs, you must believe that you're going to get better. You must. Attitude of gratitude. It's essential to connect the heart with the brain. And this is what happens, and the research is backing this up for 30 years at HeartMath. Self-love, essential. It's essential to have self-love if we're going to heal. The limbic system gets coded about 3 months after the onset of pain in this part in the middle here. It's very technical, but this literally sets up the program for the chronic pain state that doesn't go away for many people. In fact, it gets worse because it's linked with memory, learning, reflexes, etc. The very basic slide that we all get taught at science and at medical school, parasympathetic, sympathetic. And, it boils down to this, we need to be more in the parasympathetic, the left side, than the sympathetic, because that's the fight, flight, running from danger, as it were, or freezing in trauma. And this is a great picture by Lorimer Moseley, or not from him directly, but a picture that he, or a term that he's termed neurotags. And these are like things going on in the brain. Just think that's your brain, and things are being created. These dendrites these are the connections to the large part of the nerve cells that you're seeing in the middle of the screen. They literally grow as you do all the stuff we're talking about. These can be memories, they can be thoughts, they can be behaviors, literally are changing in the nervous system. So let's talk about the safety meditation. So I'd like to do this. It won't take too long. So It's going to take 2 minutes. Okay. So this is called safety meditation. It came from the work of Howard Schubiner in Michigan. It's going to be published in the literature this year, 2021. And I've taken his information and formulated my own style of it. And his results show phenomenal outcomes in chronic pain, 75% reduction in 75% pain-free in patients with this. So what is it? So if you've got pain, I would like you to just sit and be comfortable. Obviously, if you're driving, don't do this, but just sit in a comfortable place. And I encourage my patients to do this morning and night in their bed. So repeat after me. I am safe. I'm completely healthy. I'm safe. I'm completely healthy. I am peace. I am joy. I am love. I am peace, joy, and love. Now visualize a place or a time or a person where you feel those safe feelings, loving feelings, healthy feelings. Now I would like you to feel those feelings. What are they? Now take those feelings and multiply by 2. Do your best with this. Imagine more of it. And when you're there, I would like to multiply those feelings by 2. So you're really stretching yourself now, pushing the limits of your imagination. Feel the love, feel the safety, feel the connection to wherever you are. And the last one, again, try. Aim for the stars this time. Aim for the stars. Really push it and embody your body with these feelings of wonder, safety, love. Now I'd like you to say, I am safe. I am completely healthy. I am safe. I am completely healthy. I am peace. I am joy. I am love. So in that meditation, I encourage you to do this morning and night in bed and spend 5 minutes, and if you can, up to 20 minutes. Really embellish those feelings, these thoughts. These neurochemistry, these hormones are being produced, I've mentioned. Neurotransmitters, peptides are being produced. You're changing the internal soup of our body. Chemical soup is changing. And it lasts for hours into your day. And if you go off to sleep with this, you're programming your brain, in the work of the one and only Wayne Dyer in his last book mentioned, this type of visualization causes 4 hours of benefits through the night. And the great thing with bedtime is we literally reprogram the subconscious. And this is where the biggest hurdle is, because chronic pain is not a conscious thing. It's a subconscious thing first. It's a program, and we can change it, and we can literally change how your body is being created day by day, moment by moment. So to wrap it up, Janet, how you heal chronic pain? Awareness. Number 1, it is the bridge from what you're doing to where you're going. Be aware. Intention to heal with your actions. Maintain the intention. Where intention goes, energy flows, and you change. Gratitude and self-love, can't beat it. Do it through the day. Safety meditation is a wonderful tool, based in science. And service, to wrap this up, give back. Give back to your community, give back to your neighbor, give back to your friend, give back to your people in your life. And then Jesus said it so well, the laws of the Old Testament is summarized in love God with all your heart, soul, mind, and strength, and love your neighbor as yourself. And when we love in service to our fellow man, woman, child, animals, planet. We can heal ourselves. We can heal our planet. So thank you.
Thank you, Dr. Wayne.